Welcome to Hersing University NU 640, Introduction to Women's Health Across the Lifespan. This video will discuss Chapter 23 from your Alexander and Colleagues textbook, as well as Chapter 14 from your Sarkio and Secor text. This discussion will serve as a brief overview of the material. Therefore, I would like to ask that you please read the chapter for additional and required information. I would also like for you to review all other required and supplemental resources. To note, this presentation will be given by Drs. Alicia Sutton and Lauren Ashton. A great place to begin is by stating that pregnancy is a normal physiologic process. However, complications can arise, and you, as the nurse practitioner, must be familiar with the normal changes of pregnancy and the possible pathologic changes that may occur so that therapeutic measures can be initiated to reduce any risks to the mother and fetus.
Pregnancy results with several hormonal changes. Estrogen surges high in early pregnancy, which causes patients to feel very tired and sleepy, so they may come in complaining of a lot of fatigue. They may also complain of mood changes, sleep disturbances, weight loss or weight gain, and what everyone will refer to as pregnancy brain, decreased memory or failure to concentrate. These are all normal physiologic changes that you're going to see in your pregnant patients. Patients will experience several skin changes, such as the angiomas and palmar erythema, which is the reddening of the palms of the hands. This will resolve after pregnancy. Patients will also have an increased chlasma. That is the hyperpigmentation of the face, also referred to as the mask of pregnancy. The linea nigra, which is the line that goes down the center of the abdomen that becomes darkened. Patients may also experience more hair growth and the darkening of the areola, the Montgomery tubercles that become more pronounced on the breast. This is just the body's way of getting ready for lactation and is a normal finding. And lastly, the striae, which is a result of changes in the connective tissue. This has a genetic predisposition, but can also occur with excessive weight gain. There's also a lot of other changes that are occurring as well. Your patient may see some mild changes with their scalp, such as excessive oiliness or dryness. The eyes have decreased interocular pressure with thickening of the cornea due to edema because you're holding on to fluid when you're pregnant. This can cause problems for those who wear contact lenses. You will not see changes in a prescription of the contact lenses during pregnancy. You just need to educate your patients that she may need to wear her glasses if this is bothersome to her. However, if you have a patient that is complaining of visual changes, then this is a different story, as visual field changes are not a normal finding and should be referred. Your patient may also have edematous gums and increased gingivitis. And in regards to the thyroid, when you're palpating a patient's neck on their initial visit, do not be alarmed if there's an enlarged thyroid. This is normal in pregnancy, but you should never feel any nodules or masses. If you do, then you should order an ultrasound of the thyroid to rule out anything else that may be going on. There's increased vascular blood flow, but a goiter is not normal. TSH levels are the same in pregnancy versus non-pregnant patients. However, there is an increase in the circulating thyroxine binding globulin during the first trimester. This will peak around the 20th week. It will increase the mother's basal metabolic rate. Again, these are all normal changes that occur during pregnancy. As you can expect, there is a lot of endocrine changes that happen during pregnancy. Of course, the pituitary gland enlarges during pregnancy. So you have decreased FSH and LH because you have estrogen saying we don't need any follicles coming out. And you have an increasing prolactin level in anticipation for lactation. Hematologic changes occur as there's almost a doubling of the blood flow. The hematocrit hemoglobin is sometimes almost diluted, so you're going to want to be thinking about iron deficiency anemia. It's very common in your pregnant patients. Actually, iron deficiency anemia is the most common anemia you will see in your pregnant patients. It's most obvious during the second and third trimesters. Then you will also see a generalized immunosuppression. Your patients will have an increased white blood cell count, and it's not unusual to see that 15,000 or higher. It's not due to an infectious disease process, but instead due to the increased leukocyte production or leukocytosis. You will also want to be very aware that your pregnant patients are at a risk of a DVT. This is a concern that you will monitor through 4 weeks postpartum. Following the hematologic changes, you will see an increased cardiac output. Decreased vascular resistance occurs because of progesterone, if you remember, as a smooth muscle relaxant. So you will see a decreased vascular resistance, which increases your cardiac output and increases your heart rate. So it's not uncommon to see a pregnant woman come into your clinic with a tachycardic rate. The heart will move up with advancing pregnancy, as the diaphragm will also elevate and move to the left. So you may hear some changes in your heart sounds. You may hear some functional systolic murmurs. That's because of the doubling of the blood volume pushing through those valves. There is more turbulence, which creates the murmur. But make note that a diastolic murmur is not a normal finding. Blood pressure in the first part of pregnancy may also be decreased, of course, because of the decreased vascular resistance with the progesterone, until about the middle of the pregnancy. Because of the decreased vascular resistance, you can also see edema in the lower extremities. In terms of respiration, you have increased tidal volume and increased airway resistance. Shortness of breath is experienced by about 60 to 70% of women during their pregnancy. Again, the diaphragm will elevate and shift to the left, and you will also see patient complaining of increased nasal congestion. So I want to take a moment and advise you that diseases of the respiratory system, such as asthma, may actually be exacerbated during pregnancy. Your text actually mentions that 1/3 of affected women will get better, 1/3 of them will remain the same, and 1/3 of your patients will actually worsen. So please ensure that your patient has a rescue inhaler. Treatment is a stepwise approach, and any exacerbations require immediate medical attention. The baby and mama needs good airflow for proper development. Breasts will also increase in size and may be very tender. This actually may be the first thing a woman notices that warrants her to take a pregnancy test. You will want to encourage good supportive bras during this period. It's not uncommon to see colostrum leakage beginning as early as 16 weeks, so you will also want to educate your patients about this so they don't become alarmed. Now moving on to GI. Your patients will be talking to you a lot about nausea and vomiting because they will be absolutely miserable and want you to do something to alleviate the discomfort. Actually, nearly 70% of women in the United States complain of this. Additionally, increased saliva production, heartburn, and constipation are all normal in pregnancy. Up to 85% of women complain of heartburn, with 50% of them beginning in the first trimester. Heartburn is due to decreased lower esophageal sphincter pressure that's caused by that increasing progesterone. Because if you remember, progesterone relaxes smooth muscle. So when the sphincter relaxes, then you will have regurgitation of the gastric juices. You will want to recommend small frequent meals, separating fluids from their meals, elevating the head of the bed, and not laying down right after your patient eats. There may be some changes with the liver as well. The alkaline phosphatase will sometimes increase twice the normal level due to the growth of fetal bones. The AST, ALT, and bilirubin will either remain normal or can decrease. Progesterone will also impact the gallbladder by impairing its ability to contract, which leads to stasis and cause an increased risk of gallstones. So you may often see women with complaints of symptoms of gallbladder disease. Encourage diet and lifestyle changes if it's mild, but if it's severe, you may need to image and refer for possible surgery.
The genitourinary tract. You can get hydronephrosis with the dilation of the ureters. This is normal in pregnancy. Therefore, you have a higher risk of developing a urinary tract infection and the advancement to pyelonephritis due to the stasis of the urine. And of course, the increased renal blood flow. You have doubling of the blood volume and therefore increased GFR. As stated in your SECOR text, your analysis may be considered for at-risk patients to check for glucose and protein. This test used to be done at every prenatal visit, regardless of risk, so you may see that some practices still do so. However, it is no longer an ACOG guideline or standard of care. Proteinuria and hematuria are not normal. These are a reflection of renal function, and when we talk about preeclampsia, that is something to consider. What is the organ that is going to be most sensitive to changes that are related to preeclampsia? The kidney.
You will also note changes with the external genitalia. You may note a hyperpigmentation. The pubic hair may lengthen. As the mother nears term, pelvic congestion can occur with swelling of the labia majora and possible vulvar varicosities. You may also assess the bluish color of the cervix. Do you know what this sign is called? It is the Chadwick sign. So the bluish hue of the cervix is normal, and the mucosa will soften and thicken. What is the sign for softening of the cervix? It is called Goodell's sign. And then Hagar's sign is the lower uterine segment that will soften, and you will notice this upon your bimanual exam. The uterus will hypertrophy in early pregnancy as it enlarges due to estrogen. After the 12th week, it is significant and will begin to protrude out from behind the symphysis pubis. This is why you'll be able to begin auscultating fetal heart tones. Your patients can begin noticing Braxton Hicks contractions. These are irregular contractions where there's no pattern to them. Of course, you will rule out preterm labor and then just reassure your patient. And the ovaries? The ovaries are now quiet because you have that corpus luteum that is secreting progesterone. Progesterone is the most important hormone in terms of allowing the early pregnancy to get established onto the endometrium or uterine wall. Eventually, HCG will begin to be produced by the placenta. This then feeds back to the corpus luteum so more estrogen can be continuously produced. By 7 weeks gestation, the placenta will take over the majority of this work. On a side note, as it really pertains to high-risk pregnancies, progesterone can be given to women who have a history of early pregnancy loss and also in women who have preterm labor in later pregnancy. Some other things that you may see normal in pregnancy is joint relaxation. This is due to progesterone and relaxin. Relaxin, as you know, is released at the later part of pregnancy and actually causes relaxation of the pelvic bones. Mother Nature has designed it so when the fetal head is pushing through the bony pelvis that there is a bit of a give. The problem is that relaxin is released well before a woman goes into labor and does cause some discomfort. Some women have said, it feels like my hip is going out of socket when I'm walking because she's carrying the extra weight. You just need to advise her that this is normal. Sometimes the abdominal binders help to decrease this and offer a little bit of support. Encourage patients to wear low supportive shoes as the center of gravity is changing. Of course, you are also going to see increasing lordosis, which is the exaggeration of the lower spine, and the pregnancy waddle.